Hello, my name is Masa Zanta,
I'm Mohan Patel.
and we are Pulmonary and Critical Care Fellows at Temple University Hospital. The purpose of this educational video in the workshop is to provide Lewis Katz School of Medicine medical student an experience in pulmonary function testing done in real lab with real patients.
Pulmonary function tests are non-invasive tests that can help measure lung volumes, capacities, flow rates, and gas exchange. At Temple Lung Center, we use BodyBox and VMAX software for measuring pulmonary function tests. There are 4 variables that determine the predicted normal values that we measure on PFTs. First one is height. Taller the person, the larger the lung volumes. Next one is age. Patients typically tend to have decline in their lung function after age 25. Race. Caucasian people and African American people of the same height. Caucasians will have a slightly larger lung volume than African Americans. The next one is sex. Males on average have larger lung volumes than females. There are 3 parts to pulmonary function test. The first one is spirometry, second one is lung volumes, third part is diffusion capacity.
We will first begin with a patient with normal lung physiology. Using Mullen as our example, we will review 3 parts of pulmonary function testing, including spirometry, lung volumes, and diffusion lung capacity. We will see how these tests are performed and then try to interpret them together. We will then move to our first patient with chronic obstructive lung disease and do the same, and then with our last patient with interstitial lung disease. The material in this video is meant to supplement the discussion questions that will be reviewed during this workshop. Patients are usually seated during spirometry. Nose clips are used to help prevent air leakage through the nasal passages. The mouthpiece is placed inside the mouth between the teeth, after which patient takes a deep breath and exhales forcefully, which should typically last 6 seconds.
Relax, breathe. Get ready. Fast breath in, hard push. Hold it out, hold it out, hold it out, 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 and big breath in, pull it in. Relax and catch your breath.
Usually 3 maneuvers are performed. An acceptable maneuver requires a sharp peak in the flow curve and an expiratory duration greater than 6 seconds. Reproducibility is determined by comparing the FVC values of all the trials, and comparing these values, the highest 2 values for FVC should be within 0.15 liters of each other. And same thing for FEV1. When we get the results for spirometry, we get 2 curves. The first one, which is here on the left of the screen, is called the flow volume loop. As you see here, it consists of 2 parts. The inspiratory part, which is this part, and the expiratory part, which is this part. During expiration, the patient is asked to expire forcefully and fully. The volume that we get in the first second is expressed as FEV1, and the total volume expired is expressed as FVC. On the right hand of the screen, we see another curve, which is the volume time curve, or the time volume curve. Same thing as we saw in the first graph. FEV1 is the volume expired in the first second. Typically, an accepted maneuver is when patient expires for 6 seconds or more. In this graph, patient expired for about 9 seconds. The total volume expired is vital capacity or forced vital capacity in this test.
Now going on to the second part of the pulmonary function test, which is the lung volumes. To measure the lung volumes, we usually use body plethysmography, which is the gold standard for measurement of lung volumes. There are alternative methods available, which include helium dilution, nitrogen washout, and measurements based on chest imaging. Common lung volume measurements that we measure during this part of the PFTs include vital capacity, functional residual capacity, residual volume, expiratory reserve volume, inspiratory capacity, and total lung capacity.
To perform lung volumes, patient is first asked to sit in a small airtight chamber that is completely see-through. Patient then puts nose clips on their nose to shut off air through the nostrils. The mouthpiece is placed inside the mouth between the teeth. Patient is first asked to breathe normally against the mouthpiece. Patient will start panting with the shutter open and then the shutter will close while patient continues to pant. This is where measurement of lung volumes is made using Boyle's law. After this maneuver is made, the shutter will open again and patient will breathe normally. Then, patient performs a deep maximal inhalation followed by complete expiration. This will enable the test to measure total lung capacity, forced residual capacity, and residual volume. Measuring lung volumes using body plethysmography depends on Boyle's law, which states that the product of pressure and volume of a gas at a certain temperature remains constant. Looking at this equation, using body plethysmography enables us to measure the pressure at the mouth, which approximates the pressure in the lungs, the pressure in the box using a pressure probe, and instructing the patients to pant against a closed shutter will cause the chest to expand, and thus less volume of air in the box. This will help us measure the change of volume, which will be FRC.
Get ready and pant, and out, and out, and out, and out, and out, and out, and out. Keep it going, perfect. Breathe normal, normal, hands down, normal. Big breath in, blow it out easy, push. Nice, keep going, a little bit more, a little bit more, a little bit more. Hold it out, a little bit more, a little bit more. And deep breath in, pull it in. Good.
So this is the normal body plethysmography tracing for a normal patient. The blue tracings here indicate different phases of the test that we just saw. Initially, as you can see, this is patient breathing normally. This is the tidal volume. This is when the patient starts panting. This is when the shutter gets closed. And this is when the shutter opens again and patient starts breathing normally. At the end of this, this is when the patient starts taking a deep breath and blows it out completely. This is another tracing of the same body plethysmography graph we saw earlier. This is patient breathing normally, and this would be your tidal volume. Tidal volume essentially means patient breathing in and out normally, and the amount of volume that you move in and out is your tidal volume. In a typical patient, or normal patient, the tidal volume is usually around 500 to 700 cc's. Next thing we're going to talk about is the inspiratory capacity. Inspiratory capacity is the maximum inspiration from end tidal volume to total lung capacity. What I mean by that is, as you can see here, at the end of expiration, patient starts to pant during the test, and then when the panting is done, at the end of panting, patient takes a deep breath. So from the end of expiration, from the tidal volume, patient takes a deep breath to maximal capacity. This is your inspiratory capacity. Typically, in a normal patient, inspiratory capacity is usually around 3.5 liters. Next thing we're going to talk about is the vital capacity. Now, vital capacity by definition is the maximum volume exhaled after maximum inspiration. So, in this case, as you can see, we start here again. At the end expiration from the tidal volume, patient takes a deep breath and then maximally expires till they cannot breathe out anymore. And this is the vital capacity for the patient. Typically, the vital capacity is usually around 4 to 4.5 liters. Next thing we're going to talk about is the residual volume. The residual volume by definition is the volume of air remaining in the chest after maximal exhalation. In this case, as you can see, at the end of expiration, when the patient can't breathe out anymore, there is still some volume of air remaining in the lungs. That is the residual volume. In a normal patient, usually the residual volume is around 1 liters. Next thing we're going to talk about is the functional residual capacity. Functional residual capacity is the volume of air remaining in the chest at the end of the tidal volume breath. So, Here you can see this is the tidal volume, patient's breathing normally. There's still some amount of air remaining in the lung. And at the end of expiration from the tidal volume, whatever volume remains in the lung is the functional residual capacity. And lastly, the total lung capacity. So total lung capacity is the volume of air in the lungs at the end of maximum inspiration. So here you can see patient taking a maximum amount of breath. The volume at the top of this peak is the total lung capacity. We also want to make an important distinction here. TLC, or total lung capacity, residual volume, RV, or functional residual capacity, are the only things that can be measured by body plethysmography. Other parameters that we just discussed here can also be obtained with the help of a spirometry.
When you get the results of pulmonary function tests on a patient, the tests will be reported as reference, which are numbers calculated based on enhanced criteria for either Caucasian or African American. References in addition to confidence interval between the lower limit of normal and upper limit of normal for all these variables. Then you'll get the numbers of your patient. These are the actual values for these volumes and capacities, and these are percentage of these values. In our healthy subject, the patient had normal FEV1 FVC ratio, normal FEV1 and FVC, and as you can see here, all the lung volumes and capacities are also within normal.
Now on to the final phase of the pulmonary function test, which is the diffusion capacities. Diffusion capacities are single breath diffusion capacity for carbon monoxide, also known as transfer factor or TLCO. This test is quick, safe, and useful in evaluation of restrictive, obstructive lung disease as well as pulmonary vascular disease.
The single breath DLCO maneuver begins with a full exhalation to residual volume. The mouthpiece is connected to the test gas, which contains 0.3% of carbon monoxide, tracer gas, oxygen, and nitrogen. And the subject inhales rapidly to total lung capacity in less than 4 seconds, following a 10 or about 10-second breath hold. The subject will exhale quickly and completely to residual volume. An alveolar sample of the exhaled gas is collected immediately following dead space washout and analyzed for calculation of the dilution of the tracer gas and the uptake of carbon monoxide.
The next breath, just keep breathing out. Breathe it out. Out, 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 out. Big breath in. And hold it. Hold it, 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 hold it. Breathe it out. Push. Out, 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 out. Keep going. A little bit more and stop. Take your mouth off and relax. Good.
So this is the tracing for the diffusion capacity test we just performed. The top line, which is the red line, is the carbon monoxide concentration line. The second line, which is the green line, this is the intrathoracic pressure tracing. The third line, the blue line, is the lung volume. So as you can see, at the beginning of the test, patient was asked to exhale completely. This is the bottommost point. This is when the volumes in the lungs are minimal. At that point, patient takes a deep breath. And once the patient takes a deep breath, they're asked to maintain a hold for about 10 seconds. So you can see the volumes don't change. The intrathoracic pressure stays steady. If the pressure starts dropping or there is a drop in the volume, that probably indicates that there is a leak in the circuit. Once the 10-second hold is completed, as we described in the test, patient exhales as fast as possible, and we measure the concentration of carbon monoxide that is returned. We typically tend to measure the carbon monoxide concentration in the middle of the expiration. As you can see, our patient starts expiring here, but we measure the concentration indicated by this box here. The reason for that being is we want to make sure the patient breathes out all the dead space volume prior to measuring the concentration of the gas in the alveoli.
When you get the results for diffusion lung capacity of carbon monoxide, this will be expressed as reference number calculated for the patient and a confidence interval with lower limit of normal and upper limit of normal calculated for that patient, in addition to actual values of DLCO and a percentage of that reported value. Diffusion lung capacity testing measures the diffusion of carbon monoxide through the alveolar vascular surface, and any problems in that surface will cause abnormal DLCO. For example, reduction of the surface area will cause reduced DLCO, and this is seen typically in patients with emphysema. On the other hand, if there is increase in that surface thickness, which is typically what we see in patients with interstitial lung disease, this will cause also reduced DLCO. As we also know, carbon monoxide has high affinity to hemoglobin, and thus any problem with hemoglobin will alter DLCO. And that's why we see some centers actually adjust DLCO for hemoglobin. This is not done in the test here. Anemia will cause reduced DLCO, and polycythemia will cause increased DLCO.
Relax your breathing. Take a big breath in. Blow hard. All the way. Out, 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 out. Keep going. Blow, blow, blow. Do not breathe in. Don't breathe in. Don't breathe in. Push it, push it, push it, push it. Keep going, keep going, keep going. Push, 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 push. In. Big breath. Good job. Take that out. Take it out of your mouth. That's it. Take that out. Yeah, take your pinchers off. Get your breath.
Our first subject is an example of obstructive lung disease. This patient has COPD. An obstructive lung disease is a disease of the airways, and it typically limits expiratory flow, and therefore the volumes that can be exhaled. And thus, these patients have decreased FEV1 more than FVC, and thus the ratio of FEV1 over FVC is reduced. And typically these patients, on the flow volume loop, you see this shape of the expiratory limb, this coping here, is a sign of severe obstructive lung disease. Looking at the volume time curve for patients with COPD, as we see here, our patient exhalation time lasted for over 20 seconds and failed to plateau and continued to empty even after 20 seconds. This is different from our normal subject as we saw earlier, and this is typical for patients with severe obstructive lung disease.
Relax your breathing. Relax your breathing. Relax your breathing. I'm going to record a few breaths. Just breathe normal. 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 Relaxed breathing. Relaxed breathing. Keep your lips tight. Keep them tight. Relax your breathing. Get ready. Now, pant, in and out, little breath, in, out, in, out, in, out, in, out, little faster, in and out, in, out, in, out, smaller, smaller. Good, normal, normal breathing. Ease back into it, lips tight. You can put your hands down, keep your lips tight. Regular breathing, regular breathing. Relaxed breathing. When you're ready, take a big breath in. Take your big breath in and blow all the way. Blow, 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 blow. Blow, 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 blow. All that air has to come out. Keep going, 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 keep going. Blow, blow, all the way to empty, all the way. When you're done, take it out. Good job.
And our second patient has severe COPD. As you see here, The FEV1-FVC ratio, as we explained earlier, is reduced, which is less than 70%. FEV1 is also reduced at 34% predicted, which is for this patient 3.2 liters. Looking at lung volumes, as you see here, total lung capacity is increased, which indicates hyperinflation. Looking at the residual volume, it's also high, 253% of what is predicted for the patient, which is 2 liters. This indicates air trapping.
On the mouthpiece, normal breathing. Get ready. Big breath in, hard, push. Hold it out, 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 out. Big breath in, pull it in. Good, relax and breathe normal. You can take your mouth off if you need to. Catch your breath.
In contrast, with restrictive lung disease, the ratio can be normal or even greater than normal depending on the severity of the disease. In our third subject, who has interstitial lung disease, which is an example of the restrictive lung disease, because elastic recoil is greater than normal, even though the actual FEV1 is lower than normal, more FVC is exhaled during the first second, and thus the ratio can either be normal or greater than normal. Note how this curve is different from our second subject who has COPD. As you see here, most of the volume is exhaled during the first second, and that's why FEV1 and FVC are very close to each other, which explains the normal ratio. As you see here, our patient exhales most of the volume during the beginning of the exhalation time.
Get ready. And pant. And out, and out, and out, and out. Keep going. Breathe normal, normal. Big breath in. Breathe it out easy. Push all the way out. Push it, 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 push it. And big breath in. Pull it in. Good. Relax.
Going to our third subject, who has interstitial lung disease, which is an example for restrictive lung disease. As you see here, both FEV1 and FVC are reduced, but in similar amounts, which makes the ratio of FEV1 over FVC normal. Looking at the lung volumes for this patient, as you see here, total lung capacity is reduced compared to what is predicted for this patient. This is consistent with restrictive lung disease.
This concludes our pulmonary function testing educational video. We would like to thank Temple University Hospital Pulmonary Function Lab, patient volunteers, and Lewis Katz School of Medicine Basic Science and Clinical faculty. Finally and most importantly, we would like to thank Thomas Van Rijk, Assistant Director for Education Technology, for filming and editing this video. Thank you.
Thank you, and we hope you enjoyed it.